you're going to be the first person on scene of something bad that happens. A lot of calls that we run in the 911 system are at schools and restaurants. Bad things happen in all places. Anybody else? Education. Education. Knowledge is power, right? The more we know, the better off we are. So, Colonel Nicholas Sen, he's one of my personal heroes. He is sort of the godfather of he's the godfather of godfathers of trauma medicine. Swiss-born American surgeon. He was the founder of the I gotta look at my notes for this one, the Association of Military Surgeons in the United States. He was quoted saying, "The fate of the wounded rests with those who apply the first dressing." And this is true. The entire idea of the Stop the Bleed course is getting the knowledge and tools in the hands of the people who can apply the first dressing. And where are we going to use this training? As Sheriff Schrader mentioned before, the prevalence of mass shootings is horrific right now. It seems like we can't turn on the TV without seeing another story of another gunman in a public place or someone driving a vehicle through a large crowd of people. It is a very sad reality of the society we live in right now. But what's important to remember is a lot of the things that we're going to talk about today, you're much more likely to use these skills on someone you know and love at home or at work or in school or at a restaurant. Though these mass shooting events are very in your face, just like CPR, you are more than likely going to use these skills on someone who matters to you. And it's important to keep that in mind. So at work, at home, at school, outside, we have a very, very large number of people, large percentage of people in the state of Colorado who like to do adventure sports, right? I mean, this is the mecca of adventure sports in the country. The amount of trauma that can happen when someone's snowboarding or skiing, mountain climbing, it's pretty incredible. So just because we talk about the major events doesn't mean that the possibilities are not all around us. So we really have two goals from this class, and if we can achieve these two goals, I'm going to consider this a success. And those two goals are to identify and recognize what life-threatening bleeding looks like. And the second goal is how to intervene and how to treat it. And we're going to focus on three primary techniques. The first one being direct pressure, the second and third being tourniquet use and wound packing. Does anybody here have a higher level? Can anyone raise their hand if you're an EMT, first responder, paramedic, nurse? Any doctors in the room? Oh, thank you. That's great. No doctors. Well, in that case, I can tell you whatever I want. No one's going to correct me. So this is don't worry about the names or anything of the vessels that are up here. This is a very basic slide as to how blood works in our body. And I'm going to keep this as simple as possible, but blood is literally the lifeblood of life. So blood is a delivery system. It delivers nutrients and oxygen from our heart and our lungs to our cells. And very briefly, if you look on the left side, the blue side of this diagram, that's actually our right side. You got to imagine that I'm facing you, right? Your left side's my right side. So the right side of the heart gets all the blood that doesn't have oxygen gets pumped to the right side of the heart. From there, it gets pumped out to the lungs. At the lungs, it picks up oxygen. It leaves off all the bad stuff, the carbon dioxide and all the junk that it's picked up from the rest of the body. It goes back to the left side of the heart, right side of the screen, left side of the heart, where it is oxygenated. From there, the oxygenated blood gets pushed out to the rest of the body, and that very bottom part, that's our capillaries, our tissues, our cells. Then it has the same sort of exchange that it does in the lungs, except in reverse. It leaves the oxygen with the cells, and it picks up carbon dioxide and junk and brings it back to the heart. And it's a system that is working 24/7, 365 our entire lives. So what happens is when we start bleeding, we start losing our ability to carry oxygen. And just like if you try to hold your breath, how long do you think you can hold your breath for, realistically? Someone give me a number. A minute? I think I heard someone say 3 minutes. If anyone could beat 3 minutes, I'd be impressed. It's a lot harder than it seems. But the longer our bodies go without that vital oxygen, the more our cells start to die. And as those cells and those tissues start to die, everything gets worse, okay? So when you think about blood, you gotta think about, just like they say, like, if anyone's ever taken stroke classes or anything like that, time is brain. When it comes to bleeding, blood is life. The more red blood cells we can save, the better off that patient is gonna be. So, especially when we start considering the events that might lead to some of these mass traumas, it is important to keep in the back of your mind that your personal safety is your first priority. I sort of equate it to when you are on a plane and they talk about the masks dropping down and they say you gotta put on your own mask before helping others. It's important to remember that no one calls 911 when something good has happened. No one is gonna look to you to use these skills when they're having a good day. Something bad has already happened that's led to this event. And it is important for you to protect yourself so that you don't become another victim. If you're another victim, whether that means climbing down a hill that may be icy and someone's fallen down and now they need help, or if it means being in a public area that is currently under threat, you have to make the choice for yourself how much risk you're willing to take in order to provide aid. But it is important for us as first responders to have the least number of patients possible. So making yourself a patient is ultimately not gonna be good for the greater outcome. So in any type of event that happens, it's important, stop, take a deep breath, check your own pulse, all right? Move yourself to safety, and if possible, move the victim or the patient to safety with you, okay? How are we doing on those videos? We good? Figured them out? No go? All right. We may be doing this without videos, which takes some of the pizzazz out of this presentation, but on the same note of protecting yourself and your own safety, we always suggest whenever possible, and every congregation here is gonna get a medical kit that we'll talk about throughout, but I highly suggest people keep a set of gloves with them in their medical kits. If you have us come and do one of these presentations for a smaller group, everyone will get their own medical kit, and I'd be more than happy to give everyone some gloves that will fit them. The actual chances of having any sort of bloodborne disease transfer from one person to another from a laceration or a cut is very, very, very small. Your intact skin is your best set of gloves. We wear these to not only protect us from the patients, but to protect the patients from us. When I was a brand new EMT, one of the first major trauma calls I had was a rollover accident, and I had to climb through the back window to get to the patient in the front who was trapped, and I ended up slicing my hand open on the back of his broken window. And he was very bloody. I ended up providing as much care as I could from that position. He ended up getting transported, and I realized at the end, after the call was over, that I had this large laceration across my palm, and his blood was all over me, and I was like, oh no, I don't know what this guy has. It actually turned out that he did have bloodborne illnesses, and I was panicked for 6 months. Had to go and get regular blood tests done. Even with all that, a very large laceration on my hand and direct contact with this guy's blood, the actual chances of transmission are remarkably low. It's still always a good idea to wear these. But if you do get blood on yourself doing any sort of treatment, let a healthcare provider know. Anybody, if there's ever concern about cross-contamination, the patient will be tracked. They'll track their blood, and if need be, they'll do regular blood tests on you as well to make sure that there wasn't some sort of contamination or transmission of bloodborne illnesses. Whenever possible, always wash your hands. That's one of our best techniques for preventing any sort of transmission. Where do you fit in the chain of survival? Well, as I've been alluding to this entire time, there's an old expression in EMS, when seconds count, we're only minutes away. So you are where the seconds count, all right? So in EMS, we absolutely love acronyms. So we try to keep things very simple, ABC. So the things that we're going to focus on whenever an incident happens are the ABCs of stop the bleed. First, alerting 911. Next, bleeding or recognizing it. And third, compressing to stop the bleed. All right. Alerting 911. In order for us to get there, we have to know something's happened. If multiple people are on scene, I would advise one person call 911 and get us started while another person starts care. I'm not exactly sure what the national standard is. Maybe some of my firefighter brethren can tell me. How long are we supposed to be able until we get a first responder on scene? 4 minutes? So 4 minutes. 4 minutes is gracious. Even our really urban areas, even if the incident happens a mile from our firehouse, 4 minutes can be a pretty, that's a pretty fast response time. I can also tell you that when an event like this happens, if you're treating somebody and your heart is racing, 4 minutes is gonna feel like an hour to you. It's amazing what adrenaline does to us, but it will make everything seem like it's going faster and slower at the same time. You'll look back at the incident and feel like, oh, like that, I can't believe that just happened. It seemed like it lasted 2 seconds. But in the moment, you're gonna be saying, where are these guys? Like, did they stop to get coffee on the way? It's amazing. But get us started. All right, bleeding. Identifying life-threatening bleeding. In the little kits that we're going to leave each congregation with today, there is a set of trauma shears. They're scissors that are specifically designed to make some cuts and close. It's important for us when there is a traumatic incident for us to actually see what's going on, all right? Especially wintertime, people start wearing those really puffy jackets. It can be very difficult to see all of the bleeding that can be absorbed in people's clothes. So the trauma shears that we're going to provide to you are really, they're supposed to be sort of one-time use. If you ever use them, you let us know. We'll give you another trauma kit, okay? We're going to identify where the bleed is, and we'll get a little bit more into that later. But we're going to alert 911, and we're going to start identifying the bleeding, start cutting off clothes. Yes, sir. So I can't tell you that, and I don't want to give you incorrect information. I know that our dispatchers, one of the most important things you can do when you call 911 is to know your location. It is possible to track which towers cell phone calls ping off of, but in terms of us actually getting and knowing a specific location, I can tell you from our experience that unless you tell us specifically where you are and we get that in our dispatch notes, it can delay our response time looking for people. One of the videos that unfortunately I don't think is going to play, you hear someone talking to a dispatcher and they're asking, where are you? Where are you located? And he's walking around, he's saying, we're at the park, we're at a small park. And the dispatcher's like, okay, that doesn't help me. I need to know, like, give me some cross streets. So I don't know specifically what you're referring to, but I'm not saying that very well could exist. I know that if you call 911 and you say, I am in Storyline Church in the auditorium, we're going to find you. If you say, I'm at that church in Arvada, there's a lot of churches, right? So knowing your location is very important for us to get to you quickly. Bleeding. What we're looking for to find the source of bleeding, we're looking for, when we're talking about life-threatening hemorrhages, we're looking for large volumes of continuous bleeding or pooling of blood. I just want to double check, those videos didn't pop up? All right, well, that's really too bad. So about a half a can of soda or beer or your drink of choice is enough to be considered a large amount of bleeding. It doesn't take very much blood for us to start showing signs of shock, having an elevated heart rate, of breathing quickly, panic, that impending signs of doom. EMS professionals, all the way up to doctors and surgeons, we are notoriously bad at estimating blood loss. There's a lot of reasons for that. Blood pools, soaks into carpet, runs away into the drain, gets lost in clothing. It's really hard for us to really estimate an accurate amount of blood loss. But I can tell you that it doesn't take much before we start seeing those signs of a shocky patient, of someone who's kind of going the wrong way towards the light. Oh no, this isn't working anymore, is it? Well, normally I would have a couple of videos to show you. The first video is a video of a gentleman who I believe he's in England based off of their accents. He was stabbed a bunch of times and people are treating him and they're talking to a dispatcher. People are applying dressings as much as they can, but he still has all of his clothes on. And with all of his clothes, you can see all of the blood soaking through his clothes onto the ground. It's very obvious this guy is in a bad way. One of the things I want to point out from that video is there's about 8 people standing around this guy trying to treat him. And some people are doing a great job holding pressure and treating this guy. The guy on the phone is very panicked, but he's doing the best he can to get an ambulance to him. But no one is removing his clothes. Everyone is just holding pressure on the places that they can see. Well, this guy's wearing a very large puffy down jacket. And I don't know, because this is a YouTube video, I wasn't there. I never armchair quarterback, but I do my best not to. But my guess would be that this guy was probably stabbed in his torso a fair amount. And no one was addressing any of that because they couldn't see it. So an important thing to remember whenever we're dealing with these massive wounds is to remove clothing. You're going to get really, really personal with these people. Anyone who gets in my ambulance who has massive trauma will be naked when they get to the hospital. I guarantee it. I'll do my best to cover you back up, keep you decent, keep you covered, but I want to see your entire body. Just because you have a large gash in your calf doesn't mean you don't also have an injury to your torso. So especially when we're dealing with these very large incidents, it's important that we get people naked. Believe me, they would much rather you get them naked than they die because you didn't want to take their shirt off. Anybody want to take a guess how long it takes to die from an arterial bleed that is left untreated?
3 minutes.
3 minutes. Who said that? You've taken this class before, haven't you? Twice. All right. No more. You can't do this anymore. Shh. 3 minutes. What was my brother said for response time? 4 minutes. That's a good day. What kind of things stop us, slow us down when we respond? Shout them out. Traffic. What else? Weather. Anyone be in a snowstorm in Colorado? It's awful. Misdirection, right? We don't know where you are. What else? Drivers who won't move. That's one of my favorites. Speed bump. No, we'll hit those fast. You ever seen Dukes of Hazzard? We'll fly. Anybody else? Traffic. I'm sorry? Distance. Yes. Especially if you live somewhere that's a little more rural, your response times are going to be longer. So you can bleed out from an arterial bleed in 3 minutes. And I'm going to tell you from my own experience, that's a liberal amount of time. Depending how bad the arterial bleed is, it can be a lot less than that. It could be more, depending on how bad the bleed is. But 3 minutes is sort of the number that we throw out there. So on our best day, incident happens, I happen to be on the road on my way back from the hospital, and I am 4 minutes from you when you call me, I'm still a minute behind. I'm still already a minute behind. So this is where you come into play. Arterial bleeding has a pulsatile effect to it. If you've studied anatomy at all, the heart pumps. As it pumps, it kind of has that rhythm to it. Arterial bleeding is coming directly from the heart. And if you ever see an arterial bleed, which unfortunately the other video that is not going to play shows, is it kind of looks like a sprinkler. Any bleeding that looks like a sprinkler is a serious bleed, okay? The other type of bleeding that we talk about a lot is called venous bleeding. It's bleeding that's from the other side of the diagram. It's from the blue side. It's the stuff that's not pressurized that's returning to the heart. Now, that being said, venous bleeding can still be very significant. It can still cause you to die over a longer period of time, but you can go through your entire volume of blood in a few minutes on the arterial side. The venous side is a little bit slower. You got a little bit more time. But any bleeding that is pooling, that is showing through your clothes, or that is continuous, should be considered serious bleeding. Sorry, I'm trying to catch up to where I am. I have a tendency to just kind of run my mouth a little bit. All right. There are three main areas that we talk about and different treatment plans that we talk about when we refer to bleeding. There are the arms and legs, or the extremities. There's the neck, the armpits, and the groin area, which sometimes we refer to as the junctions. And then there is the core, the torso, and the body, okay? We're gonna start out here, and we're gonna work our way in. So, bleeding from arms and legs, this slide is up here, and I'm gonna add a little bit of a caveat to this. It says that arms and legs are the most frequent cause of preventable death and can be controlled with direct pressure and tourniquets. For the last 20 plus years, we have been fighting a war with mostly young, healthy gentlemen who have sustained a lot of extremity injuries, and they say preventable death. These are military personnel, but this does not necessarily translate over into the civilian population when we talk about the frequency of extremity bleeding. And does anyone want to take a guess why? Combat? What about combat? IEDs, shrapnel. Think more about why would a military personnel be more likely to sustain injuries out here than in here? Body armor. I am the most guilty person in the world of thinking that the military is so great with their with the science that they've put into trauma, because that's my wheelhouse. That's what I like to believe. We have guinea pigs in green that we get to just like play with, right? Well, that's not really the case. When it translates over into the civilian population, we don't wear body armor. So the possibility of having torso injuries is much higher in the civilian population. That being said, the part that does translate over from the military side is that massive bleeding from the extremities is easy to control if you have the right tools and the right knowledge, and when appropriately applied, is the most frequent cause of preventable death on the military side of things, okay? I'm still gonna say that it doesn't translate directly over, but massive bleeding from your extremities is something that we can easily control. And we're gonna talk about that in a minute. The second place that we look at massive bleeding is the neck, armpits, and groin, or the junctional wounds. We have some props outside that everyone will have the opportunity to play with if you would like to. These are difficult, and I can tell you that one of the big ways that we will talk about to address extremity injuries is tourniquets. And for anybody who has any sort of military experience or who's been around for a while will probably tell you that tourniquets for a long time were looked at as, if you put a tourniquet on somebody, they're gonna lose that limb, right? If you apply a tourniquet, you immediately might as well amputate that leg. It's not going to live. That's not actually how it works. Medicine is a pendulum. It swings back and forth a lot. And when I was first getting into EMS, the use of tourniquets was sort of this gray area. Now, tourniquets are the greatest thing since sliced bread. All right, we treat every major bleed in the extremities with a tourniquet, and it works a lot. It works well. Tourniquets are fantastic, and we're going to go over how to apply them. Injuries in the junctions, the groin, the neck, and the armpits are hard because they are higher than we can apply tourniquets to. They have a lot of major vessels that go through here, jugulars, arteries, right? A lot of blood passes through these areas, and you can bleed out from them very, very quickly. But you can't apply a tourniquet because it's too high. So we're going to address those types of wounds with wound packing and direct pressure. The reason I'm harping on this a little bit is because even someone who is very skilled at doing this, who has done this a lot, it is very hard to do this effectively. It's a skill that even I think some of our best providers don't practice enough, and I can tell you, I did a lot of this in Afghanistan. I have not done it once since I've been back here. And if I had to do it right now, I'm not sure how successful I would be. We're going to discuss the application of it, but it is important to understand that this is a difficult skill. And then the final area that we look at is the body, the torso, the chest, the abdomen, or sometimes what is called the box. All right, this is the box. Any major injury that happens in the box, unfortunately, a lot of these are very, very critical patients. You got a lot of really important stuff here. You know, heart, lungs, all your intestines, liver, things that bleed really rapidly. Unfortunately, there's not a whole lot we can do. When you get into the back of an ambulance, some ambulance companies have a few different extra tricks that we can throw in there, but for the most part, these patients need bright lights and cold steel. They need rapid transport to a surgical center where they will get treated by a doctor in a sterile environment. A lot of trauma to the core doesn't bleed a lot externally. You can see someone and they get shot and you say, why is there's not that much blood? It's because they're all bleeding internally. This is sort of a big chamber that you can lose your entire volume of blood into very, very rapidly, but not actually see it from the outside. These patients are the ones that getting us going quickly have the highest probability of survival because ultimately what they need is fast transport to somewhere that they can do more. And there are medical agencies around the country now that have started carrying blood or blood products. It's sort of the new, latest, greatest thing for EMS personnel. And in those patients, this is phenomenal because we are bridging the gap a little bit further and bringing the blood to the patient instead of bringing the patient to the blood. Yes, sir. So the question was about taking a person to the hospital, like in your vehicle, or rapidly instead of waiting for us. And what I can tell you is that I will always condone calling 911 because especially with some of these patients, we have some drugs that we can give. We have some treatments that we can provide en route to the hospital that will help their likelihood of survival that may not happen in the back of your vehicle. Another thing that you want to consider in that type of situation is can you continue to provide treatment while you're driving? If you're there by yourself, putting them in the back, if you have to let pressure go in order to drive your vehicle, you're probably not going to be doing that person any favors. Now, that being said, if you're across the street from a trauma center and something happens, and it's 5 minutes for an ambulance to get to you or 30 seconds for you to walk across the street. Right. And that's all stuff that has to be taken into consideration. And I can't give you any sort of black and white answer. And the reality is medicine is not black and white. It is ever evolving and it's ever changing. And everything we do is very much a shade of gray. So those are decisions that, yes, you have to make. I will never say that it is always appropriate to take someone to the hospital yourself. I will never say it is always appropriate to call 911 when higher level of care is right next to you. Those are choices that, yes, you will have to make, and you're going to have to take those kinds of things into consideration and make the choices for yourself. Yes?
What about a bleeder?
I'm sorry?
What about a bleeder?
A bleeder? Like someone who's massively hemorrhaging?
I know. Hemophilia.
Oh, so like someone on blood thinners?
Yeah,
Or
blood thinners. And AFib. How would you treat me?
Well, so I'm going to treat you the exact same way I'm going to treat somebody else having a traumatic incident. The prevalence of blood thinners, especially in some of our more elderly population or people who have bleeding disorders, is much more common now than it used to be. People do bleed more now than they do when they're, young kids. We're still going to treat those patients the same way. There are a few other considerations on the EMS side of things that we have to put into patients who are on thinners and who have some other comorbidities. But in terms of what we're talking about here today, you're going to treat them the exact same way. But what I can tell you is somebody taking blood thinners, it's going to take a lot more time, a lot more pressure, and a lot more effort to get that person to stop bleeding. You will be treating that person from the point of contact until we get there. And if you're doing a good job, you might be coming to the hospital with me. All right, now for the meat and potatoes. We've talked about all this bad stuff that could possibly happen. Here's what we actually do to treat it. All right, this is the good stuff. This is the happy part. So pressure. This is the most common sense treatment, right? Anybody who's had kids who, fell and cracked their head or any sort of trauma that you deal with in your day-to-day life, what's the first thing you do? You put a rag on it, right? Oh, I hurt my arm. I grab it, I push. It's a human reaction for a reason, right? We apply pressure to the majority of wounds. And for a large contingency of venous bleeding of that blue side of the heart, direct pressure is going to work. If someone's bleeding fairly massively and you can get your body weight over top of them and just provide direct pressure, if that's all you do and that stops the bleeding, fantastic. We're ahead of the game. We would like to, whenever possible, apply clean gauze. We want to apply things that are sterile as best we can to avoid infection. That being said, never don't apply pressure because you don't have something clean. If someone has that massive of a bleed, they're going to get antibiotics at the hospital, okay? Large amounts of pressure, use a rag, use gauze if you have it, and once you make that initial contact with the injury, you don't let go. Because what you're doing is that rag, that gauze that you're applying pressure with, you're starting to develop a clot right where that gauze touches their skin. And if you remove it, you've just removed the clot, and now we gotta start over again. So that initial point of contact, you keep it there. So the question was about using QuikClot. If you have QuikClot available to you, I absolutely would say go ahead and use it in this type of situation. QuikClot is a gauze that is impregnated with a clotting agent that makes you clot faster. QuikClot is fairly expensive, and not everybody has easy access to it. In your little medical bags that we're gonna give today, everyone will have a roll of Curl-X. This is what we primarily use in EMS, and this works for the vast majority of bleeding that will be stopped with direct pressure. This is just a way for us to start that clotting process, and maintain that pressure. If you have QuikClot available to you, well, actually, I want to talk to you after this. Yes, sir.
The question in your photograph
Mhm.
that's up there, it would appear that the responder has not cut away the clothing. They might have just seen all the blood at the surface, and they're applying pressure to that spot. What's the best practice in a situation like that?
So in this type of event, what I would say is if you see someone bleeding through their clothing, absolutely apply direct pressure immediately. Ripping through the seams of jeans and denim if you don't have scissors is really difficult. What I like to tend to do is I cut through the seams and then rip, because denim rips really easily when after you've taken away its integrity. If you had a pair of scissors, what I would probably do is I would have somebody apply that direct pressure and hold while somebody else cuts their jeans off, cuts their clothes off. This is sort of a continuum, right? Like we gotta kind of work as a team, work together. If you have the ability to open up the clothes and identify the wound, I would do that, but I wouldn't waste time trying to do that in order to find a pair of scissors. If you need to take someone's pants off, undo their belt, absolutely do that simultaneously, but maintaining that pressure is really, really important.
Arthur,
Yes,
you have a comment on how much pressure to apply?
all of it. The whole amount. I can't tell you specifically. It really will depend on the person applying the pressure, the victim who is having pressure applied to them, and the extent of the wound. Anyone who's had a minor cut on their arm knows it doesn't take a whole lot, right? You just kind of sit there, you wait, you're watching TV, you're doing whatever you're doing, whatever, you can do other things. Large wounds, you literally could be in the push-up position leaning on somebody, applying as much pressure as you could. And those are the types of people who are going to need the next level of treatment that we're going to talk about. Again, it's a continuum. Tourniquets. So, tourniquets, as I mentioned before, are the greatest thing since sliced bread. And they have made a huge comeback in trauma medicine. Every kit that we're going to give out today is going to have a tourniquet in it. Which picture am I on? This one? Okay. Tourniquets, do we have one of the trainers? Mind if I grab that from you, Cap? Is this a trainer or is this it's a real one? All right. This is, so my disclaimer is I am not paid by anybody except Arvada Fire Protection District. We are not sponsored by CAT Tourniquets or by any other agency. This is what we bring. Oh, we have a trainer? Okay. The blue ones are trainers. They're made to be used over and over. The black ones are like the real deal that you'll all get. This is what we use at Arvada Fire. This is what is most commonly seen in the military. These are called CATs, which is Combat Application Tourniquet, or CAT Tourniquets, which is Combat Application Tourniquet. But, we're firefighters. Got to keep it simple. Pick things up, put them down. The way these work is the band, you'll notice, is about 1 inch to 2 inches wide. There is Velcro or hook and loop all the way around the band. Inside of this band, there is we'll call it a ribbon. As you twist this windlass, the ribbon tightens. So you're using mechanical advantage from your own body to twist and create a tightening. Tourniquets work by providing a large amount of pressure over a broad space onto pushing your arteries against your bone structure. So the question that comes up a lot during these classes is the use of improvised tourniquets, which I'm going to jump ahead for a second. The use of improvised tourniquets, because these are great if you have them with you, right? And hopefully after this class, everyone's going to always have their tourniquet on them. I can tell you in Afghanistan, everyone had to have one of these on them at all times. I had to sleep with mine on me. But if you don't have one of these, you might have to improvise, right? People make the common mistake when they are improvising tourniquets in using things like shoelaces, things that are thin, because they think if I just pinch this off, right, the bleeding's going to stop. It's not really how it works. You want to have that pressure spread across a wider area. So that's why these tourniquets are wider, okay? I am going to ask my faithful compadre. There are videos that I really want to show, but unfortunately we can't, so I'm going to have to do this in person. When these come out of their package, they come in this nice little, oh, it's in my pocket. They come all nice and shrink wrapped. They come like this, and they come out of the packet, they come put together. When these are designed to be able to apply to yourself. These are specifically designed with soldiers in mind who are in the middle of a gun battle, and they have to be able to apply it to themselves in the middle of combat. So it comes out like this, all right? These can be reset like this. If you're dealing with somebody who has a very particularly large thigh, or maybe they have an injury where a bone is sticking out and you don't want to take this and start sliding it over their tib fib while they're screaming at you, you can open it up, rethread it just like you do a belt, pull it back on itself, Velcro to itself, and then you twist the windlass. What I'm going to show you, this is very important, and this is going to set you up for success. It's the small things that make a big difference. When I'm putting this on, yes, when I'm putting this on, this initial pull to make this tight is really important. I want to get as much of this slack, I want to get as much of this slack out as possible. And what I like to do, it'll work either way. I can pull or I can push, but I like to hold the windlass, the stick, in one spot and use it as an anchor and use my body weight and pull as much of this out as I can.
Sorry, my muscles are so big.
It's massive. She's been hitting the gym. The reason I want to do that is because I only want to twist this 2 to 3 times. If I'm at the point where I'm twisting this and twisting, it's starting to lose its effectiveness. It's also taking up a lot of time. I can pull out all this slack really quickly, and then I'm going to twist the windlass as much as I can. Now, I'm going to tell you right now, this hurts. If you're applying a tourniquet appropriately, they should care more about the pain that you are inflicting on them than they do the injury. And I promise you, people are going to try to take this off. Part of your job is going to be to make sure they don't, because this stays on until they get to the hospital. So I'm going to start twisting, and I'm going to twist until it stops. All right, I think I could probably get one more in there. You put the windlass back into the clip, run the whatever loose part you have around, and then over top, you put your time marker. You can see on here it says time. In all of the little medical bags that we have, you're also going to have a Sharpie.
Time.
No, we're just going to leave that on. Oh, yeah, that's good stuff. All right.
Thank you.
You're welcome. In all of your medical kits, you have a Sharpie. It's important to note the time on these. God willing, you will never have these on for a time that is too long, because ideally we're already on the way. Ideally, they're going to be in a surgical center within the next hour. People can leave these on for extended periods of time. The jury is still kind of out on what the actual timeline is before you start having irreparable damage. I can tell you when I was in basic training, I had one of these on for 4 hours. I couldn't feel my hand. They took it off. My hand was numb for a long time, but I was fine. I still have my arms, sort of. That is the combat application tourniquet. When we put these on, we want to put them on 2 to 3 inches above the point of the injury and not on a joint. And that's because if someone starts bending their arm, bending their knee, it's going to come loose. What I'm going to tell you, because I like keeping things simple, again, firefighter, right? Simple is easy. If you are at the point where you're putting one of these on, I want you to put it as high up on a limb as you can go. The reason is, in a stressful event, we have the tendency to get tunnel vision. Human beings, what we do. If Amber here has, we're gonna say she's been stabbed, and someone came in and they just started going to town, and I get tunnel vision on the fact that she has this large laceration right here because someone did a nice slice job. And I say, oh man, okay, I can treat that. Here's my handy dandy tourniquet, and I'm gonna come and I'm gonna be a hero, and I'm gonna make this all nice and tight, and I'm gonna crank this down. I'm not gonna do this to her again because I feel bad enough already, all right? Great, sweet, and the ambulance comes, we're gonna high-five everybody. Yeah, great, awesome. Well, no one noticed the fact that she was also stabbed right up here, and she's bleeding from her brachial artery, right? Especially she's wearing those big puffy jackets we're talking about that everyone wears now. So if you're in a situation where you're applying one of these, I would highly suggest that you go as high up as possible. Because even if the injury is down here, if you stop the bleed up here, this is gonna stop, all right? Questions on that? Sir? If you want to repeat that now that you have a mic, please do.
Hello? Yeah, the question was 2 to 3 revolutions, full revolutions, and then the second question was, is there an age limit? So children down to infant, is there plate type where you don't apply it?
These can be used as to children as young as, I believe it's 1 year old is where the cutoff is that there have actually been studies for. Little kids and infants, direct pressure is going to work in 99% of incidents because their blood pressure is already significantly lower than adults, and the person applying the pressure has a lot more strength and ability to get down to those small arteries with just direct pressure. I have never had to apply a tourniquet to anybody under the age of 5. I've always been able to control it with direct pressure. So essentially, this part right here is rigid, this plastic piece. If this is too big to go around their arm or their leg, then you're gonna have to apply a direct pressure. And your question about the twists of the windlass, 2 to 3 is sort of like what you're shooting for. What you're really shooting for is until you physically cannot twist it anymore. If you put this on, the reason I was saying you wanna do it about 2 to 3 times is because if I put this on super loose, and I don't get a good crank here, and I'm just sort of like, okay, I throw that on, and now this is loose. Before I even really start applying any sort of pressure into her arm, I'm already 3 or 4 spins in before she's actually gonna have any sort of effect. And when you start doing that, you're also twisting the ribbon that's on the inside here, and you're losing effectiveness. So if you get a good crank on that first pull, you should, I mean, if you really get a good crank down, and depending on where it is, it could be 1, maybe 2 spins before you physically cannot twist it any further. And the big sign, if you've done this correctly, is gonna be what? The bleeding stops, right? Bleeding stops. You've done a great job. Again, high fives for everyone. I think we're good, yeah. Once a tourniquet is in place, you don't remove it, all right? This stays on until we're in the surgical center. If this does not work, and you've done everything that you can with 1 tourniquet, put on another. 2 is always better than 1 in this situation. You can see in this picture, in this picture, he's got 2 tourniquets on. Really like strong people who have really massive legs, 2 tourniquets is probably, it's gonna happen. Fluffier people, 2 tourniquets, also very likely. Legs, tourniquets, very likely. Arms, usually 1 is good.
So what happens if you have a burn in addition to the laceration?
Whew, man, you're getting deep in there. I like these questions. You're still gonna treat you're gonna treat the bleed. We're focusing on the bleeding at this point. If you have someone who's massively burned, they're gonna need a burn center. And focusing on keeping that patient warm is really important because when we get burned, we lose our ability to thermoregulate. It could be the middle of August outside 120 degrees and someone could be hypothermic after they've had a burn. So that's a great question. It's a little, that's sort of next level, but we have to keep the burn in mind. But in terms of actually treating the initial injury, focusing on stopping the bleed and keeping the patient warm are the two most important things that we can do.
Question,
Yes, sir.
second tourniquet should be put above the first tourniquet?
If you are able to, yes. If you get that as high as you can in the first place, it may be really difficult to apply another tourniquet above it. If you need to, go below it. But ideally, if you do apply the tourniquet down low, the next one should be above it. Belts are great. We unfortunately, so Stop the Bleed does not condone the use of improvised tourniquets, because the reality is improvised tourniquets are not, they're not studied, they're not proven to work, and everything that we do has to be based on science. If those of you remember the Boston bombing, a lot of improvised tourniquets were used in the Boston bombing. And there were a lot of lives who were saved. One of my really good friends was one of the first ambulances that showed up on scene during the Boston bombing, and she will be the first person to tell you that the actions of people who were there who applied improvised tourniquets of all different sizes, shapes, even if they were using things that would not necessarily be considered the best option, people survived the Boston bombing that wouldn't have otherwise. So even though I can't condone using improvised tourniquets, belts are a good option. The biggest thing is, as hard as you crank something down like that, unless you actually have a way to use mechanical advantage to continue to tighten it, if someone's at the point of needing a tourniquet, just cranking a belt down might not be enough.
Quick question. If you're putting two tourniquets on somebody, do they need to be a certain distance apart, or can they be right next to each other?
You can stack them pretty close. If you can leave a little bit of space between them, that'd be great so they don't interfere. One thing that happens when you put two of these on is the actual, because human nature, again, we always put things on the exact same way. You're gonna put this on right next to the one you just put on, and this windlass is gonna be right in your way as you're spinning the next one, and the windlass is just gonna keep getting caught as you do it. So you may need to give yourself a little bit of distance. You also might wanna offset. Okay, these work no matter where you put them, circumference-wise on the leg. I would also, this is really getting deep in the weeds, and I'm trying not to make this too complex. I want to keep this very simple. When you put these on, I would not, if it's possible, don't put the windlass right here, because this isn't a joke but as I'm spinning this is going to get caught in my groin, all right? So putting it up here, have all this free real estate to work with, all right? If you start putting it on and it's in the wrong spot, go with what you got, all right? This is any port in a storm. If you're applying a tourniquet, you're doing a great job already, and I'm proud of you for having a tourniquet with you. Okay, we're gonna move on. This is the video that we can't get to play, but it was essentially what I just did to Amber, except this person complains a little bit less about it, but whatever. I love you, Amber. All right, tourniquets. They can be applied over clothing. I've talked a lot about getting people naked. If you're putting one of these on, you can put it over clothing. Make sure they don't have you're not putting it over pockets where they have a bunch of junk. Every guy here who has back problems, I know where you're sitting. You're sitting right on your wallet, right? Wallet's got to come out. You want to apply it as close to skin as possible, but don't hold off putting on a tourniquet looking for scissors, all right? These can go on over clothes. These are meant to go on over clothes. As I said before, tourniquets hurt. They are very uncomfortable. Eventually, their arm will go numb. Their leg will go numb. They will stop complaining. And hopefully, they'll still be alive to keep complaining in the future. And thank you for your efforts. Second tourniquet might be required. These are some pictures of some other tourniquets that are on the market. Again, we are not sponsored by CAT. This is just what we use, and it's very commonly seen. There are soft tees. There are a number of other pneumatic tourniquets as well that use air to use that compression. there's a lot of different options out there, and anybody who is looking to purchase tourniquets, I can provide you some resources, and you can make the choice of what's right for you. Yes.
I've heard that you can also use like a blood pressure cuff as a tourniquet and pinch, if that's what you have.
It's definitely possible. I can tell you from some of my patients that they complain about how tight my blood pressure cuff is. Yes, you can. The problem with blood pressure cuffs is that they are made to deflate. So unless you're there actively holding pressure on it, they will slowly start to lose pressure. It would not be my first choice, but it's another resource that's out there. This is a couple of the pneumatic tourniquets that are on the market. Again, if anybody wants any of this information after class, I'd be more than happy. And the last thing we're going to talk about in terms of treatment is packing. As I was saying before, packing is very, very difficult. The idea of packing is that you're so high up in the junctions, in the groin, in the armpits, in the neck, that you can't get a tourniquet around it. Tourniquets ideally need to be at least a couple inches above an injury to really be effective. Well, the highest I can get a tourniquet is about here. And right here and in here bleeds a lot. So what we're going to do is we are going to apply direct pressure immediately to the injury inside the person's body. And the way that's going to work is you are going to ideally have that part of the body exposed. You're going to clear out any of the excess blood that is pooled, because if someone has a hole in them, blood is going to pool there. You can clear it out with your hand, you can clear it out with a rag, but you're going to try to get a visual on the vessel that is bleeding. Has anyone seen Black Hawk Down? Black Hawk Down? Yeah, it's a great movie, right? I love that. But the scene where they're trying to pinch off the femoral artery and it's like retracting up into the guy's groin, that's essentially what you're trying to do, is you're trying to get a view of what is actually bleeding, and you're going to take your gauze and you're going to apply direct pressure right to where it's bleeding. You are then going to maintain pressure on that spot as you do a hand over hand or thumb over thumb type technique to maintain that pressure. And you're going to fill the entire void that is in that person's junction until you have some excess Curl-X or any sort of excess product above the skin. And then you're going to get in that push-up position or however you can, and you're going to apply as much pressure as possible. That pressure is then going to transfer down through the dressing and hopefully maintain pressure directly on that wound, okay? This is really difficult, especially because as you move that patient, all of the junctions, the neck, the armpits, and the groin, are all where our joints are. So as soon as that person starts moving, they're going to start moving your hard work. So we want to, that is the perfect example of if you've done your job really well and I show up on scene and you've got the bleeding to stop, you might be coming to the hospital with me, because I'm not going to take your gauze away and take your body pressure off of this injury so that I can see it. I'll trust that you've done a good job, all right? We don't want to break that clot. And if you've done a good job, that bleeding will stop, and I'm just going to use you as my mechanical advantage on the way to the hospital. Or if you have somewhere important to be, I'll take one of my brothers and tell them to put pressure on it instead. This is another video that actually showed some wound packing that, okay, we're good on time. 2:15, right? Including the, okay. Man, gotten way ahead of myself. We can practice some of this out here. It is very difficult, and until you actually have the opportunity to do it for real, you probably won't have a full appreciation for how hard it is. But if you do it appropriately, you will save someone's life. Yes, sir.
I'm this much horrified right now. If I am trying to deal with someone in this level of trauma, myself, who doesn't do it all the time, de-escalate, get focused, get yourself to the point where it's like, yes, I'm going to do this.
What's your name?
John.
John, I'm going to have you hold on to that question for me because I am going to address that in a few minutes. But I'm very glad you brought that up because it's something that we all need to talk about. This is a video that unfortunately isn't going to work, but it's essentially what we can do out there with practicing to pack wounds and to hold pressure. This video, this lady is using Quick Clot, which is awesome. And if you have that available to you, please use it. Bleeding control in children. We already talked about this a little bit. In all but extremely young children, tourniquets should be, you should be able to use them. And they should be treated the same as adults when it comes to trauma. If they are too small to use a tourniquet, direct pressure should work in virtually all circumstances. And same thing for junctional packing, large, deep wounds. You can do the same thing with kids. We generally try not to look at kids as small adults in medicine because they are very different in a lot of ways. When it comes to trauma and trauma medicine and stopping bleeding, our treatment models are essentially the same. A couple other frequently asked questions. Some of these we've already touched on. Impaled objects. If somebody is impaled with something, we don't remove it. If somebody is impaled, the object that is in them is actively acting to prevent them from bleeding out. So we as EMS providers will transport them with that impaled object inside of them, and they will take it out in the surgical suite. The only 2 times you ever want to remove an impaled object for somebody is if it is blocking their airway and they are unable to breathe because the impaled object is in their trachea, or if they have already passed and you need to do CPR and you can't do CPR because of where the impaled object is. Both of those situations are very extreme situations, and I would say the likelihood of seeing those are very small. Improvised tourniquets, we talked about a little bit. Yes. I've actually run that call. Well, what we're going to do is we are going to come and we are going to cut the picket fence, and that picket fence is going to take a ride in the ambulance with us. We still don't want to remove them.
So if we were trying to treat that situation, we would treat around that.
Correct. Actually, in those types of situations, a lot of times what we're going to end up doing is stabilizing the object in them so that it moves as little as possible while we're transporting. What else we got? Loss of arm of the leg. That's a common concern that people have when they put on tourniquets. It's not something that we need to be concerned about. You can have tourniquets on for a very long time without causing any prolonged injury. Pain, as I said, tourniquets are painful. Leave them on. Make sure they don't take them off. And other questions? We're going to get to what John asked just a minute ago. Yes, sir. Mm-hmm. So yes, I'm assuming you have a higher level, some other medical training above this. So I'm sorry, sir, what's your name? Ron was asking about checking for a distal pulse after you put a tourniquet on. That is something that we do, and that's actually what I was doing with Amber, is I was checking to see if she had a pulse, because if you stop arterial bleeding, your pulse should stop as well. So that's how, when we do these trainings, we see if someone's actually really put the effort into cranking that thing down and stopped bleeding, because that radial pulse or that distal pulse, that pedal pulse will stop. We don't really teach that in this course so much, because one of the reasons is unless someone's had some kind of experience telling everyone where to look for pulses, is kind of hit or miss. So we're really looking for for the bleeding to stop. Yes, sir.
For packing wounds, you might have said this. Are you just using gauze if you don't have like Quick Clot or something like that?
Yep, 100%. The Curl-X that we're going to have in the medical kit, that's perfect for it. and we'll practice a couple techniques out there. There's a few different ways that you can do it. If you don't have gauze with you, using someone's shirt or clothes might be their best option. As I mentioned before, if they're going to the hospital for something like this, they're going to get antibiotics. Anything else before we move on?
Outside of the internet, I mean, you can order this stuff, but it seems pretty specialized. Where do you buy?
I'm glad you asked. Wow, it's like you saw this. Further preparedness. All right, again, we are not sponsored by any particular organization. The pictures up here, this is a kit that is provided by North American Rescue. There's a lot of different companies out there that provide kits for people. I can give anybody the information here that they would like. This is becoming a lot more commonplace in schools and some churches and a lot of public places right next to where they keep the AED. It's a sad reality that we want to have a lot of tourniquets available sometimes. It's not always an isolated incident. So you're able to buy kits like this of various different sizes with various different pieces of equipment in it. You can build your own. Some of the stuff you can just order online. What I would caution you about with ordering stuff online is knockoffs. People who want to get cat tourniquets, you can buy like 20 cat tourniquets for $5 on Amazon, but they break. Like if you ever actually need to put them on, they snap, they don't work. I'm speaking from personal experience. So you need to get the real thing, and they're a little bit more pricey, but you can order them online. And I can give you any of the, any of the links that you might like. Lastly, remain calm, all right? All bleeding does stop eventually. And then this is a little bit more on the personal side for me, and why I really wanted to address John's concern first and foremost. I know we have a large group of religious people here, and sometimes it is someone's time. We can do everything in our power to treat someone, and we can treat someone to perfection, and they may still die. I can tell you that I still in my professional life wonder on a lot of calls if there's more I could have done. If I've made a mistake, if I had done this faster, or this differently, would that person have had a different outcome? And the sad reality is, hindsight's always 20/20. If you make the choice to treat somebody, the action of doing something is going to be better than the action of doing nothing. You all need to understand that it is still very possible that they may not have a good outcome. And however you all learn to deal with that is important. This being a faith-based summit, I think that a lot of people turn to religion, and I think that is a fantastic way to deal with some of the heartaches that come with this. I know a lot of people turn to less ideal things, and I think we all know what some of those things are. I would highly advise anyone who goes through anything like this, especially if it involves somebody who you love and care about, that you talk to somebody, whether that be somebody in your church or a professional or someone who was there with you. Part of the stigma about post-traumatic stress and some of these things that we've been dealing with for the last forever that are really now only coming to the surface, we need to take that stigma away. I've had 3 friends kill themselves since I've been back from Afghanistan because they didn't call me. So talking is important. Dealing with these things is important. It's not easy. But as John mentioned, if you are at that point where you feel like you need to do something, do it. All right? Standing back and not doing something is going to be a lot worse. I guarantee you, because then you're going to absolutely feel like there was more that you could have done. So that is, in summary, personal safety. You can't help someone if you're a victim yourself. Alert 911. get us on the way, make that gap a little bit smaller, identify the bleeding, cut the clothes, get your eyes on it, compress with pressure, packing, or tourniquets, and wait there until help arrives. Yes, ma'am.
Can you talk a little bit about the Good Samaritan law?
I can, but I won't. I'll talk to you about it offline. Okay. Yeah, it's a very good question. It's not something that I am very well versed in, and I've been doing EMS since I was 18. So our rules are a little bit different, and I don't want to tell you something wrong to a large crowd of people. So I may actually have some of my command staff answer that question for you. Anybody else? All right. Oh, one. Yes, ma'am.
I actually took this class over at St. Anthony's a couple years ago. Do you still offer it at different places where we can actually go and do the hands-on and all that?
So what we're going to do from here is we have about 20 to 30 minutes. If we have some props set up outside that we can practice doing some wound packing, practice putting on some tourniquets. If you've done this a few times before, I'd ask you to please give everybody else an opportunity to get their hands on. This is the first time I have actually taught this course to a large group of people. The one slide that actually unfortunately didn't make it up here is our contact information for Arvada's community risk reduction. You can contact our CRR department, and you can set up for myself or for any of my comrades to come and give a similar presentation. And if we give the presentation to smaller groups of people, every single person should be able to leave with their own medical kit instead of having to share one per congregation. So we can offer that wherever you like. We are Arvada's fire protection district, but we have some leeway in terms of where we can go. The big point of all of this is to give everybody here the knowledge and the tools so that you have the ability to have a positive effect on someone's life. So I will, yes, Captain.
And to answer your question, it is offered other places around the city. Arvada Parks and Rec have put it out to all of their people, all of the employees of the city, and St. Anthony's continues to have other classes as well. So if you have people,
Oh, yeah. So to answer your question, there are other classes available. St. Anthony's does promote this class as well as other hospitals. We do as well from Arvada Fire, but there are other opportunities for other places to take it. And so if you want to go again, or if you have people that couldn't make it today, you could get them into a class.
The American Red Cross, that's also out in the lobby, they also provide this class as well. Sir.
What about our liability?
So with these techniques, you're not exposing yourself to liability. It's similar to what was being asked about the Good Samaritan law. If what you're doing is within your knowledge and skill ability, you can't be held liable if you're not the one who caused the injury, you're not the one who's liable for treating the injury. Now, that being said, if you say to yourself, I think this person needs an airway, and you go take a pen and jab it in their neck, that's a different story. Like that's opening up a liability because you're doing something that's really outside of your training. But these techniques, applying direct pressure, putting on tourniquets, these are techniques that are within the civilian scope of practice for best practices. Everybody here can get a certificate for today if you would like one, and it's something that you can put on your resume if you'd like. It's a good course to have, just like CPR, but you're not going to be exposing yourself to liability by putting a tourniquet on somebody.
Even if we have to cut a lady's clothes off? That's just,
I know it's
What was the
splitting.
question?
The question was like if you're exposing yourself to liability by like cutting someone's clothes off.
So I'll answer that. So
This is Captain Putfark. He's one of our EMS captains for Arvada Fire.
Hi, everybody. So going back to the question of the Good Samaritan law, this goes along with the same thing of nobody's ever been sued for doing the simple tasks of trying to do CPR, trying to stop the bleed. Where you get into trouble, like Arthur said, is if you do something that's truly negligent. You're grossly negligent, like, oh, they're bleeding, and I'm going to put a tourniquet around their neck. That would be problematic. So, as long as you're following the simple rules of direct pressure, tourniquet, compressing the wound, and packing the wound, just like we talked about today, you're totally fine.
And in terms of like cutting people's clothes off and exposing them, if you cut someone's clothes off who has not been injured, they might not be too happy about that.
Or they might.
But I have never seen somebody who has been in dire straits be upset they lost their Calvin Kleins. So, and if they are, they probably should have been calling for help in the first place. So the question was about consent and giving consent and implied consent. Somebody who is unconscious or doesn't have the capacity to give consent, there's something called implied consent. It says that anybody who would be in their right mind with the right mental capacity would accept help. If somebody is telling you, don't touch me, I don't want help, forcing them to the ground and helping them, not gonna look good. That's where you might expose yourself to some liability. But if someone needs these interventions, they want your help. And if they don't tell you, if they're not saying, don't touch me, it's fair to assume that you are taking actions to save their life. If you start doing something and they say, get off me, I don't want your help, get off them. As soon as they're unconscious from loss of blood, they're giving you implied consent. That's not a joke. That is true. So this is one of these fine lines that we walk in EMS sometimes, is because sometimes there are people who don't necessarily want our help, who we have to help. It's a call that happens more often than you might think.
You wouldn't want to carry that to the point of taking off the tourniquet if they told you to.
No, I mean, these are, very rare situations. If you're putting on a tourniquet because someone has a massive arterial bleed, if they're pushing you off and they say, I don't want your help, and they want to take their own tourniquet off, that's on them. But as I said, tourniquets hurt. If you're doing it right, it should hurt. They shouldn't want you to be doing that anymore. That's the kind of thing where you're going to have to be kneeling on someone and saying, I'm doing this to help you. This is to save your life. It's not comfortable. It'll get better. You got to talk people through some of that stuff. But these events, people want help. I want to leave at least a little bit of time for us to go get our hands on some stuff, because this is really the most important part.
I just wanted to say, anybody who thinks they're squeamish or whatever, I would suggest you go do this, because this is an inanimate object, and you can see what it looks like, and you know it's not a person, and it will probably help you in case you ever have to do it.
Thank you very much. It's very good input and insight. If we can break up into whatever kind of groups you all would like, we have a few minutes to try some of this stuff. I have some of my fellow brothers out there who are here to help assist through going through some of these motions. I will also just come right back here, and if anybody wants to come ask any questions offline,